Okay. Let's start. Okay. I made it is not a quick summary. I try to put a comprehensive summary of the guidelines. I hope we have the time to do everything I prepared. I don't think so. So today we will start with the early pregnancy care module. First is nausea and vomiting with pregnancy. This guideline is very, 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 very important. You must have at least 2 or 3 questions from this guideline every exam. So this guideline, I cannot stress how much important this guideline is. It's very easy, not a lot of information in it, but it is very important. So the incidence of nausea and vomiting with pregnancy is 80%. So 80% of all pregnant women will have nausea and vomiting. 0.3 to 3.6 of them will have hyperemesis gravidarum. Hyperemesis gravidarum, the recurrence of it, there is no specific figure, but we can, if there is some Norwegian hospital, they said that the recurrence with them was 15.2%, but for the self-reported diagnosis, it varies from 8 to 81%. Okay, how to diagnose nausea and vomiting and hyperemesis? For nausea and vomiting, we need to know that this happened in the first trimester. Usually starts between the 4th and 7th week. The peak is the 9th week. And this is a question. This point is a question. It came before. And it resolved by the 9th week in 80% of women. Hyperemesis gravidarum, this is also a question. The triad, this exam. In January exam, this question came. The triad of a 5% pre-pregnancy weight loss, dehydration, and electrolyte imbalance. This is a very important. You have to know these 3 criteria. This triad is very important. Okay, we use the Puke classification for classifying the severity of nausea and vomiting, and this will help us in the management. Okay, this is the Puke classification. We have 3 questions we ask the patient. First, in the past 24 hours, how many times or for how long did you feel nauseated? The second question, also for the last 24 hours, how have you vomited or thrown up? The third question, have you had any retching or dry hives? If yes, we will give a score. For the nausea, if she said not at all, this is a score 1. 1 hour or less, this is score 2. 2 to 3 hours, score 3. 4 to 6 hours, score 4. And more than 6 hours, it is score 5. So 1, 2 to 3, 4 to 6, more than 6. Here, I don't want you to memorize it like this. Flip it around. So I didn't throw up at all. It is 1, 1 to 2, 2, 3 to 4, 5 to 6, and 7 or more. It is the same as here. So the vomiting and retching, if you flip this around, it will be the same as here. So you will not have to memorize a lot. So also no time, never. So it is 1, 1 to 2, 3 to 4, 5 to 6, 7 or more. This have never came, but now they are, as I told you, they are experiencing a lot of new points in the guidelines. So they can, usually they will give you as a score. They will give you this one with a Puke score 12, with a Puke score 7. They will give the score from the start. But at least have an idea about the score, how we score it. Okay, so a patient come with nausea and vomiting. First, we need to exclude any other cause of nausea and vomiting. So we have to do all of this examination and investigation. First, from the history, We need to know if this is a recurrence or no, so we have to ask about the previous history. We need to do the Puke score. We need to exclude other causes like abdominal pain, urinary symptoms, infection, drug history, chronic helicobacter infection. We need to exclude this. Then we will go for the examination. We will start with the vital, temperature, pulse, blood pressure. Then we will go for oxygen saturation, respiratory rate, abdominal examination, weight, signs of dehydration. This is very important. The weight and signs of dehydration, very important to know if this patient have hyperemesis gravidarum or not. Also signs of muscle wasting and other examination according to her history. Investigation, we will do urine dipstick because sometimes abdominal pain due to UTI can cause vomiting. Midstream urine as well to exclude urinary tract infection. Urea and electrolyte, because hyperemesis and nausea and vomiting cause electrolyte imbalance. And this may put the patient in a state of convulsion due to the imbalance in the electrolyte imbalance she had. And also for hyperemesis gravidarum, in order to diagnose hyperemesis gravidarum, we must have electrolyte imbalance. What electrolyte imbalance can we see? We can see hypokalemia, hyperkalemia, hyponatremia, dehydration, renal disease. All of this we can see. Full blood count for infection, anemia, and hematocrit. Also blood glucose monitoring to exclude maybe this is diabetic ketoacidosis, not hyperemesis gravidarum, or not nausea and vomiting. Ultrasound scan to confirm the viability and to exclude multiple pregnancy and trophoblastic disease, because there is a theory that maybe this is due to high HCG. Maybe nausea and vomiting is associated with high HCG, and high HCG can be found in patients with multiple pregnancy and trophoblastic disease. So we have to exclude this. Also for refractory cases, before refractory cases, these cases who are not responding to treatment, before we in refractory cases or history of previous admission, we need to check thyroid function tests, maybe hypo or hyperthyroidism, liver function test, calcium and phosphate, amylase to exclude pancreatitis, and ABG to exclude metabolic disturbance. So, as we said, hyperemesis and nausea and vomiting are associated with hyponatremia, hypokalemia, low serum urea, raised hematocrit, ketonuria, with metabolic hypochloremic acidosis. And this is a question, this came before. Metabolic, with nausea and vomiting, what disturbance, what acid-base imbalance we get? We get metabolic hypochloremic alkalosis. Okay? If severe, maybe she will develop metabolic acidemia as well. Okay. 2/3 of these patients may have abnormal thyroid function tests. So 2/3 may have abnormal function test, thyroid function, and this came before. He will give you a patient with thyroid with nausea and vomiting, and she has thyroid function test that is not normal. In this patient, we do nothing. We just treat the hyperemesis or the nausea and vomiting and check after this, because the nausea and vomiting can cause the thyroid imbalance. Okay, the biochemical thyrotoxicosis here, as I told you, this biochemical thyrotoxicosis resolves as the hyperemesis gravidarum improves, and treatment with antithyroid drugs is inappropriate. We don't give anything. We will just treat the hyperemesis, and after this, it will resolve on itself. Liver function test is abnormal in about 40%. So 2/3, which is about 66%, will have abnormal thyroid function test, and 40% will have abnormal liver function test. Bilirubin level can be slightly high, but we will not find that this patient have jaundice. She don't, although the bilirubin is high, she don't have jaundice. And serum amylase also can be mildly elevated. Ultrasound scan, for any pregnant woman, we have to do an ultrasound scan. We have to confirm the viability, and in this patient, we have to rule out the multiple pregnancy or the hydatiform or the trophoblastic disease. We need to rule out these causes. Differential diagnosis, as we said, peptic ulcer, cholecystitis, gastroenteritis, hepatitis, pancreatitis, genitourinary condition like UTI or pyelonephritis, metabolic condition, neurologic condition like and drug-induced nausea and vomiting. All these can be differential diagnosis. Okay, how we manage? This one is important. How to choose the best modality to treat this patient. First, we have to know the Puke score, and according to this, we will manage. So if the score is between 3 and 12, so this patient we can be managed in community, and life and dietary change is just the treatment for her. If the Puke score is 13 or more, and there is no complications and not refractory to antiemetics, like we gave her antiemetics, she is responding to antiemetics, but we cannot manage her well. But if she is not responding, it can not be put here. This patient should not be refractory to antiemetics. So 13 or above, and there is no complication and not refractory to antiemetics. 3 criteria have to be there. The score, she is not refractory to antiemetics, and there is no complication. Okay, if all 3, we can go for ambulatory daycare till there is no ketonuria. What we will do for ambulatory daycare, I will tell you in a while. Okay, any Puke score with complications or unsuccessful ambulatory daycare, we will go for inpatient. Inpatient, she will take the same as ambulatory, and we will add thromboprophylaxis, and she will be on multidisciplinary team. And here is the only place we can consider steroid. We know that steroid is the last choice for us, and we can only give steroids in an inpatient setting. Okay, so inpatient management should be considered if there is at least one of the following. When to go for inpatient, if she has continuing nausea and vomiting and inability to keep down oral antiemetics, continued nausea and vomiting associated with ketonuria and or weight loss despite oral antiemetics. This is refractory to treatment she is taking, and still she is losing weight. Confirmed or suspected comorbidity, like she have urinary tract infection, inability to tolerate oral antibiotic, so this one will go for inpatient. Okay, women who have vomiting but are not dehydrated, we can go for community setting with antiemetics, support, reassurance, oral hydration, and dietary advice. If women are unable to tolerate oral antiemetics, okay, so or oral fluids, she cannot take anything by her mouth, we can go for ambulatory daycare. What we will give? We will give parenteral fluids, parenteral vitamins, multi and B complex, and the antiemetics. And this came as a question last exam. This point came as a question. And he was asking about which parenteral fluid we will be giving. And we will say in the next slide. Women who have recurrent nausea and vomiting and hyperemesis despite adequate ambulatory daycare, treatment should be managed as inpatient, as we said here, who will go for inpatient due to the associated complication, in particular electrolyte imbalance and nutritional deficiencies. Okay. Therapeutic options. What we give for antiemetic. Women should be asked about previous adverse reaction for antiemetic, especially the metoclopramide. We know that metoclopramide have extrapyramidal manifestation. So we need to ask her if she had any previous reaction to this drug. Also, metoclopramide, it is safe, it is effective, but in pregnancy, the risk for extrapyramidal manifestation is more, so especially with pregnancy, as I said, so we have to use it as second line. These are the drugs we are using. The names here, I will give a look. I know every time if he is asking about cyclizine, but now they are changing the question, so we need to know every single drug. So usually when he gives the options, he will give you 3 or 4, these 4 and one of these. These 4 are easy to remember. The corticosteroids, the ondansetron, the domperidone, and metoclopramide, all of them are easy to remember. So if it is not one of these, it will be the first answer. So we go for cyclizine and prochlorobrazine and the bromethazine and the chlorobromazine. These are the first choice. Cyclizine, we give 50 milligram oral, IM or IV, every 8 hours. Prochlorobrazine, 5 to 10 mg, 6 to 8 hourly, oral, or 12, 8 hourly, IM or IV. Sorry. And for the chlorobromazine, it's 12.5 to 25 mg, 4 to 8 hourly. Excuse me.
السلام عليكم. هو في صوت؟ معلش اصلا مش سامعة حاجة.
أنا كمان ما سامع حاجة، شكله عندها المشكلة
Sorry for
الدكتور.
this. Let's continue. Okay.
أوكي
So for the bromethazine, we give 12.5 to 25 mg, 4 to 8 hourly, oral or IM or IV or rectal. Chlorobromazine, we give 10 to 25 mg, 4 to 6 hourly, oral IV IM, 50 to 200 mg every 6 hours, 6 to 8 hours if rectally. The second line is metoclopramide, domperidone, and ondansetron. And for the third line, it's corticosteroid like hydrocortisone. We give 100 mg twice daily IV. And once the clinical improvement okay, we will convert to prednisolone 40 to 50 mg orally. Okay? But
هي
as
دوزز هنا مهمة
I
دكتورة
told
أميرة
you before,
يعني
usually the cyclizine is the one coming in the exam.
مهم
Okay,
نحفظ
this one,
الدوزز.
as I told you, this is the question that came. What is the best rehydration regimen? As we said before, we can give this, the IV hydration plus multivitamins and vitamin B12. We can give all of this. So what is the regimen? We give normal saline and potassium chloride. Normal saline and potassium chloride, both together. And this is administration guided by daily monitoring of electrolytes. It is the most important. Monitoring of electrolytes is the most appropriate intravenous hydration. Dextrose infusion are not appropriate unless the serum sodium level are normal and thiamine has been administered. So we don't give dextrose unless we give unless the sodium levels are normal, and we give thiamine as well. Dextrose containing solution can precipitate vernix encephalopathy, and we will talk about vernix encephalopathy after some time. Okay. And vernix encephalopathy usually happens when thiamine is deficient. Okay, so we need to give each day intravenous dextrose. We need to give 100 mg of parenteral thiamine with it. Complementary therapy, ginger is the best. This is all the results is with ginger, but we need to be cautious when we are giving it to patients with gastric problems, because it has a stomach irritation effect, and it can have interaction with beta blocker and benzodiazepine. Aquastimulation and like aquapuncture and aquapressure, women may be assured that these are the aquastimulation, it is safe. Aquapuncture aquapressure may improve the nausea and vomiting. Hypnosis should not be recommended. As we told any patient admitted, we will give her thromboprophylaxis, and we should avoid any iron-containing preparations. Vernix encephalopathy. This is, as we said, due to deficiency in thiamine, which is vitamin B1. Classically, it comes with blurred vision, unsteadiness, confusion, memory problems, and drowsiness. As you see, there is no convulsion with vernix encephalopathy. When we have a convulsion in case with nausea and vomiting, it is not vernix encephalopathy, it is electrolyte imbalance. Okay? So on examination, there is usually nystagmus, ophthalmoplegia, hyporeflexia or areflexia, gait and or finger nose ataxia. Therefore, thiamine supplementation is recommended. As we said, we give 100 mg per every day of intravenous dextrose. When should we consider termination? if all therapeutic measures have failed. And there is a study that found that 10% of pregnancy complicated with hyperemesis end in termination. And 10% of these termination were offered steroids. So there is the reason for termination is that we didn't give them the full extent of the treatment. We didn't go for the third line treatment. Prominent reason for termination, inability to care for the family and self in 66.7%, and fear that they or their baby could die in 51.2%, and that the baby could be abnormal in 20%. This chart and follow-up, we need to have serial scan to monitor fetal growth, especially patients with severe nausea and vomiting. Women with hyperemesis gravidarum and low pregnancy weight gain, they are at increased risk of preterm delivery and low birth weight. And this is nausea and vomiting. I told you it is a very simple guideline. It is a very small guideline, but it is a very, 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 very important guideline. You have like 3 or 4 questions every exam minimum. Okay, so now we will go for recurrent pregnancy loss. Also one of the most important GTGs. Usually we get questions from this. You will have 1 case or 2 from this guideline alone. This is a constant question as well. What is the recurrent pregnancy loss? What does it mean? It means loss of 3 or more consecutive pregnancies. Every single word in the definition means something. 3 or more. So we cannot consider anything under 3 as a recurrent pregnancy loss. Consecutive. So if she had 1 successful pregnancy in between, this is not considered a recurrent pregnancy loss. Affects 1% of couples trying to conceive, and 1 to 2% of the second pregnancy miscarry before 24 weeks. So 1 to 2% of second trimester pregnancy miscarry before 24 weeks, and it affects recurrent pregnancy loss, affect 1% of couples. Risk factors, we have 8 risk factors: epidemiological factor, antiphospholipid syndrome, genetic factors like parental chromosomal rearrangement, embryonic chromosomal abnormalities, anatomic factors like congenital uterine malformation, cervical weakness, endocrine factor, immune factors, infective agents, and inherited thrombophilic defect. We will talk about every one of these with some explanation next. So first, the epidemiological factors. We have 2 main epidemiological factors here: the age and number of previous miscarriage. The age, you have to know this by heart, because he will give you a patient at any age and he will ask you what is the risk of miscarriage in his case. So from 12 to 19, it is 30%, 13%. For 20 to 24, it is 11. 25 to 29, 12. For 30 to 34, 15. For 35 to 39, it is 25. And for 40 to 44, it is 51. And more than 40, it is 93. Number of previous miscarriage, it is 40% after 3 consecutive miscarriage. And the prognosis worsen with increasing maternal age. So this number can go higher. Previous live birth does not preclude a woman of developing recurrent miscarriage. So if she has a previous live birth, this doesn't put her in less risk. Also, we have the cigarette smoking and caffeine. Back in the old days, they have linked them to adverse or to a pregnancy loss, but now they are saying that the evidence is not, it may be not a causative effect, like it is not the cause, but maybe an association. Heavy alcohol, it is toxic to the embryo and fetus. Obesity, responsible for sporadic and recurrent both. So obesity is a prominent cause of miscarriage. Antiphospholipid syndrome, this is the most important treatable cause for recurrent pregnancy loss, and this is very important. Antiphospholipid syndrome refers to association between antiphospholipid antibodies like lupus anticoagulant and cardiolipin antibodies and anti-beta-2 glycoprotein 1 antibodies. And the names are important because before sometimes he was asking about the names of the antiphospholipid antibodies. Now, as we saw in the last exam, they are trying to get some of the very old questions. They are researching some of the very old questions they used to bring. So, what is the adverse pregnancy outcome? We saw like it is association between the antiphospholipid antibodies with adverse pregnancy outcomes. What is the adverse pregnancy outcome? Like 3 or more consecutive miscarriage before 10 weeks, 1 or more morphologically normal fetal loss after 10 weeks, or 1 or more preterm birth before the 34th week of gestation owing to placental disease. How does antiphospholipid cause miscarriage? First, it can inhibit the function and the differentiation of the trophoblast, activation of the complement pathway at the maternal fetal interface, resulting in local inflammatory response. And in later pregnancy, it can cause thrombosis in the uteroplacental vasculature. This is how it causes the adverse effect. The effect of antiphospholipid antibodies on trophoblast function and complement activation is reversed by heparin. So this adverse effect can be reversed by heparin. Antiphospholipid antibodies are present in 15% of women with recurrent miscarriage. In women with low risk obstetric history, it can be found in 2%, in less than 2%. The live birth rate without intervention is 10%. This is without intervention. The genetic factors, as we said, we have 2 main genetic factors, the parental chromosomal rearrangement and embryonic chromosomal abnormality. For the parental chromosomal rearrangement, in approximately 2 to 5%, it is found in 2 to 5% of couples with recurrent miscarriage. One of the parents carry balanced structural chromosomal anomaly. Most commonly, balanced reciprocal or Robertsonian translocation, and this was an old question that came before as well. Although carriers of balanced translocation are usually phenotypically normal, but their pregnancies are at increased risk of miscarriage, and if it didn't miscarry, they will have a higher risk of multiple congenital malformation and or mental disability. The embryonic chromosomal abnormalities, you can find it in 30 to 57% of further miscarriage. As the number of miscarriage increase, the risk of euploid pregnancy loss increased. So previously it was some embryos with chromosomal abnormalities, but with the increased number of miscarriage, the risk of euploid pregnancy loss also increased. Anatomic factors, congenital uterine malformation, the prevalence of it is not a hard figure like before. It lies in a range of 1.8 to 37.6, so it is not a hard figure. We don't know exactly the percentage of this problem. Usually, arcuate uterus, they will miscarry in the second trimester, and septate uterus, they will miscarry in the first trimester. Women with untreated uterine anomaly, they have term delivery rate of only 50%. So if they are untreated, 50% of them will go to term delivery. Cervical weakness. So the cervical weakness is most important in preterm labor, more than miscarriage. But with miscarriage, it is recognized cause of second trimester miscarriage. The diagnosis is usually both in history of second trimester miscarriage preceded by spontaneous rupture of membrane and painless cervical dilatation. Okay? Endocrine factors. We have three main diseases here. We have diabetes. If the diabetes is well controlled, it has no effect. But it is if the hemoglobin A1C is not under control, she has a high risk of miscarriage, especially if this level is very high in the first trimester. For thyroid dysfunction, they say that it is not very well linked, although in some talks they say that there is an evidence that thyroid function can affect the miscarriage rate, but here they say no, thyroid dysfunction have no effect. Polycystic ovary, it increases the risk of miscarriage, but till now we don't know the exact mechanism of this. The most important prognostic factor with PCO is free androgen index, and this we will be talking about this not here, but with the polycystic ovary syndrome guidelines. So don't mind yourself with it now. We will talk about it in this session, inshallah. Okay, the immune factors, as you saw, as you are seeing, I'm not putting anything here. It is all about complement and the difference between complement and like this, and no one understands what they are talking about. And they never bring this point in the exam. So I'm just omitting from my memory. And I'm advising you, just read it once and don't concentrate more on it, because you will just lose time trying to memorize all these numbers. Infective agents. As we know, infective agents don't have the ability to cause recurrent pregnancy loss, because for the infective agent to be responsible for recurrent pregnancy loss, it must have the ability to be persistent in the genital tract and avoid detection. And this is like no pathogen till now can cause this, and must cause insufficient symptom to disturb the woman. And usually any infection in the genital tract will have some irritation for the woman. So now torch screening is no longer required. The presence of bacterial vaginosis, this one is linked to miscarriage, second trimester miscarriage, and preterm labor. And if we treated it with oral clindamycin, it will decrease this risk. And make sure that this is oral clindamycin. Metronidazole is not. So only oral treatment with oral clindamycin is the only one responsible for decreasing this risk. Inherited thrombophilia, both inherited and acquired thrombophilia can cause systemic thrombosis. And if they cause systemic thrombosis, they can cause placental dysfunction and or placental insufficiency. And if they cause placental insufficiency, so they are responsible for preterm labor, for miscarriage, for small for gestation age. They are responsible for every adverse effect in pregnancy. Okay. Carriers of factor V Leiden and from prothrombin gene mutation have double the risk of experiencing recurrent miscarriage. So they have double the risk. Okay. Investigation for first antiphospholipid syndrome. It is mandatory for all patients. Any patient with recurrent pregnancy loss, first thing we will do antiphospholipid syndrome. antibodies. To diagnose, we have to do two positive. We have to have two positive tests at least 12 weeks apart of either lupus anticoagulant or anticardiolipin antibody, immunoglobulin G or M, in medium to high titer, which is 40 gram per liter or ml per liter, or above the 99th percentile. Karyotyping, we start karyotyping after from the third onward. So the third pregnancy loss, we will take it for karyotyping or for cytogenic analysis, and the fourth and the fifth, and like this. Every one after the third, we will go for cytogenic analysis. Parental peripheral karyotyping, where the testing of product of conception reports as unbalanced structural chromosomal abnormalities. If like this, we can go for parental karyotyping. The sporadic fetal chromosomal abnormality is the most common cause of any single miscarriage. Couples with balanced translocation, they have low risk, which is 0.8% of pregnancy with an unbalanced karyotyping surviving into the second trimester. So most of them will miscarry with the most of the pregnancies with unbalanced karyotyping will miscarry early, and their chance of having a healthy baby is 83%. So if they have unbalanced baby with unbalanced karyotyping, only 0.8% will survive to the second trimester, and if they have 83% chance to have a healthy baby. Balanced translocations are found in 1.9% of parents with recurrent miscarriage. Anatomical factors, all women with recurrent first trimester miscarriage and all women with one or more second trimester miscarriage should have pelvic ultrasound. So the first investigation is pelvic ultrasound. If there is suspected uterine anomaly, we will go for more confirmatory like hysteroscopy, laparoscopy, or 3D ultrasound. Thrombophilia, we do it only for second trimester miscarriage, and we will go for factor V linen, factor 2, which is colostrum mutation, and proteins. Treatment, we have for antiphospholipid syndrome. This is very, very important, and everyone knows it. Low-dose aspirin plus heparin. This reduces the miscarriage rate by 54%. And we need to know these are the rules for heparin here and everywhere. For VTE, for anywhere, we need to know that there is no difference in the effect between unfractionated heparin and low molecular weight heparin. Although usually we prefer low molecular weight heparin because it has lower side effects. Specifically, it has less heparin-induced thrombocytopenia. Okay? But we need to know that even with the treatment, pregnancies associated with antiphospholipid syndrome have a higher risk of complications during all 3 trimesters, like repeated miscarriage, preeclampsia, fetal growth restriction, and preterm birth. Genetic factors, abnormal karyotyping should prompt referral to genetist. Reproductive options can have like natural pregnancy with or without prenatal diagnostic test, gamete donation, and adoption. They should be informed that they have a higher risk, a higher chance, which is 50 to 70% live birth with natural cycle or natural conception in comparison with pre-implantation genetic diagnosis and in vitro fertilization, which is 30%. So let's go for the natural conception rate. Pre-implantation genetic screening with IVF in women with unexplained recurrent miscarriage does not improve birth rate. We do only this. We usually don't do this because it has no effect, or its effect is not as good as the natural side. Anatomical factors for congenital uterine malformation, there is insufficient evidence about treatment. For cervical weakness and cervical circulation, this one, it is better to be understood not here, but there with the preterm labor, when to do monitoring and how to do and what to use. It's better to be understood from the preterm labor guidelines. So I will skip this and we will be explaining it from there. Endocrine factors, there is insufficient evidence to evaluate the effect of progesterone supplementation in pregnancy to prevent miscarriage. But this, now there is some changes in this, and we will talk about it later today. Also, there is insufficient evidence about HCG. Also, the suppression of high LH among the ovulatory women, it doesn't improve the live birth rate, and there is insufficient evidence for metformin supplementation. So all of this, all of the endocrine factors have no effect. Immunotherapy, paternal cell immunization, third-party donor leukocyte, trophoblast in the membranes, intravenous immunoglobulins, all this, no effect. Inherited thrombocytopenia, insufficient evidence to evaluate the effect of heparin in pregnancy, and heparin during pregnancy may improve the live birth rate of women with second trimester miscarriage associated with inherited thrombocytopenia. Thrombophilia. Unexplained recurrent miscarriage, we don't do anything. Excellent prognosis without any, with supportive treatment only, we get 75% of live birth rate. So we do nothing. We just reassure and tell her you have 75% of having a live birth in the future. This is like a simple summary. If there is 3 previous first trimester miscarriage, we will do anti-cardiolevin antibodies and anti-lupus antibodies. We will do ultrasound for uterine malformation, karyotyping from the third miscarriage. Those only if there is some indication, like hemoglobin A1C for women with diabetes and thyroid function test with women who have symptoms only. Karyotyping, if there is, as we said, if the karyotyping came as unbalanced translocation, we will go for parental karyotyping, and genetic counseling should be offered. So I already have this, but I don't have the time today to do it. I'm sorry. We will do it tomorrow. I will not wait for. Usually my second session will be on Thursday, but this I will not be waiting till Thursday. I will do it inshallah